to thank the organizing committee for this kind invitation. Today, I'll be presenting some of our experience in managing chronic mesenteric ischemia. By definition, chronic mesenteric ischemia is insufficient blood supply to the intestine caused by atherosclerosis of the mesenteric artery in more than 90% of cases. It's an uncomfortable zone for the vascular surgery because at that time this specific area is scarce and a lot of controversy is present in this disease, starting from the diagnosis of mesenteric angina with the clinical history, the key to the diagnosis, and the classic patient for mesenteric ischemia is a female patient, smoker in her fourth and fifth decades, presented with mesenteric pain, significant weight loss, and in severe cases diarrhea. On examination, there is nothing specific, and once suspected cases for mesenteric ischemia, the first imaging modality will be diagnostic ultrasound, with up to 90% diagnostic accuracy for hemodynamically significant mesenteric artery stenosis. Again, a lot of controversy about the criteria for mesenteric artery stenosis. In our unit, we use these measures for the hemodynamically significant mesenteric artery stenosis. If single vessel affection only on the duplex ultrasound, so the diagnosis of mesenteric ischemia is unlikely, and I think this is because of the extensive collateral circulation between the mesenteric arteries. So the diagnosis required affection of 2 out of the 3 vessels. Once it is confirmed on the duplex ultrasound, then you will need a cross-sectional imaging to map for the disease before any surgical or even endovascular intervention, either CT angiogram or MRA angiogram. We always recommend to look at the sagittal images, and if you did MRA, you will still need to do at least non-contrast CT to assess the calcification in the aortic wall and mesenteric arteries. For the treatment of chronic mesenteric ischemia, again, a lot of controversial issue. Will it be endovascular approach or open surgery? Your target vessel will be the SMA only or both CA and SMA. Unfortunately, there is no RCTs directly comparing both endovascular and open surgery for mesenteric ischemia. So I think it's a pragmatic approach to start with endovascular therapy first and keep the open surgery for field endovascular therapy or patients not candidate for endovascular revascularization, patients with median arcuate ligament syndrome, young patients with vasculitis or mid-aortic syndromes. When it comes to mesenteric bypass, will be antegrade bypass from the supraciliac aorta or retrograde bypass from the infrarenal aorta, iliac arteries, or aortic graft. So some of the cases in our unit, first case was 73-year-old female, non-smoker, presented with 15-month history of postprandial abdominal pain, weight loss on background of hypertension, hypercholesterolemia, and renal artery stent to solitary functioning kidney. CT angiogram show occlusion of the celiac axis and SMA origins. So we tried to do angioplasty, failed SMA angioplasty, and we succeeded to put stent in the celiac axis, which kept her free of symptoms for 3 years. And then she came with recurrent symptoms and had redo angioplasty of the celiac axis stent. 1 year after the redo angio, she came unfortunately with recurrent symptoms, and her CTA showed occlusion of the celiac axis stent. The recon CT, as you can see, show extensive calcification of the whole aorta and solitary functioning kidney. So decision was taken to operate, and I think no one will put supraceliac clamp for this lady. So we decided to do retrograde approach used from the common iliac artery to the SMA. 3 years after the bypass, she came with recurrent symptoms and bilateral intermittent claudication. Duplex ultrasound suspected proximal common iliac artery stenosis. And MRA confirmed the diagnosis with patent graft, as you can see, with stenosis in the proximal common iliac arteries, putting the graft at risk. So she had bilateral kissing iliac stents and patent graft, as you can see from the left iliac artery to the superior mesenteric artery, which kept her free of symptoms for only 12 months. And then she came again with distal graft stenosis, mostly at the site of calcified long saphenous vein valve, for which she had angioplasty, stenting, and remains asymptomatic for another 3 years. Second case, a typical case for mesenteric angina, 53-year-old lady, smoker, hypertension, on background of 2 years history of abdominal pain, weight loss, negative endoscopy. CTA showed chronic total occlusion of both celiac axis and SMA, referred to vascular outpatient clinic, but unfortunately ended up to E&E with a severe form of chronic mesenteric ischemia, persistent abdominal pain, significant weight loss, diarrhea with no abdominal signs. We thought acute on top of chronic mesenteric ischemia, so we brought her immediately to the hybrid theater. Trial of SMA and celiac axis angioplasty was failed. Decision was taken to do laparotomy. Inspection of the bowel showed viable bowel and ended up by quick iliac to SMA bypass. She underwent uneventful recovery, discharged 3 days later, and we got her on our graft surveillance scan. Duplex ultrasound before the discharge, then at 6 weeks for the first follow-up in the clinic, then at 3 months, and every 6 months for 2 years at least. The 12-month duplex ultrasound follow-up showed stenosis at the proximal anastomosis with peak systolic velocity more than 800 centimeters per second. Underwent successful balloon
Dear doctor,
angioplasty.
your time is up.
Thank you. And as you can see, the completion angiogram show distal graft patency and nice anastomosis to the SMA with patent middle colic, right colic, ileocolic, jejunal, and ileal branches, as you can see. And she remained free of symptoms after that. Last patient is 53-year-old smoker lady with 5-month history of abdominal pain and significant weight loss on background of retroperitoneal fibrosis, which required debulking and ureteric stents for hydronephrosis. So her CT angiogram showed occlusion of the celiac axis and critical stenosis of the SMA, for which she had angioplasty only without stenting. And then 4 months later, unfortunately, she came with recurrent symptoms, and CTA showed restenosis of the proximal SMA, for which she had redo SMA angioplasty and stenting. 2 years later, she kept free of symptoms from the abdominal point of view, but unfortunately she developed adhesive small bowel obstruction, and she had bowel resection and also open cholecystectomy during these 2 years in another hospital. And then she came after 2 years with severe CMI, persistent abdominal pain, diarrhea, and significant weight loss. And her duplex ultrasound showed SMA origin stenosis with peak systolic velocity more than 300 centimeters per second. And her CT angiogram showed not only occlusion of the superior mesenteric stent, of the celiac axis stent, but also fracture of the stent and dislodgement of the lower part of the stent.
Dear doctor, your time is up.
Only 1 minute. Yeah. So the center has been fractured and dispatched to the middle part of the superior mesenteric artery. So the decision at that time to operate. Actually, during laparotomy, we tried supraceliac dissection of the aorta by Mattox maneuver, but there was an extensive adhesion between the liver and spleen, and at the end of the dissection, there was a major bleeding from the adhesions between the liver and spleen, we apport the technique of the supraceliac clamping, and then we shift to take the inflow from the infrarenal aorta using C-shaped configuration of 6 millimeter ring graft to the superior mesenteric artery, and discharge it after 5 days without any complication, went to graft surveillance, and for 6 months we lost hair for the follow-up. Our conclusion is bypass or surgery for mesenteric occlusion is visible when it's done by experienced hand and tertiary center. Thank you.